Good morning. I think what we're going to do first, though, is have a commercial, and I'm going to turn it over to Dr. Samkit. Oh, Samkit, you're not on.
I want to use some slide and some roadmap of the data that we send. Okay, before that, I just want to show you some of the picture I download from Hubble telescope. Anybody know about Hubble telescope? No. Hubble telescope, the US government sent this telescope up on the high up, so you can take picture of the solar system, the universe, send it back to Earth without interfere by mek. So what is this picture? Any volunteer? Volunteer รูปอะไรครับ โลก The Earth from far away. Somewhere in here is what? Right here, anybody know? Saudi Arabia, correct. Up to that arrow, probably Iraq. Okay. Behind, probably Thailand. In Thailand, probably somewhere in Chiang Mai. A tiny dot on whatever you see there is Chiang Mai campus. Somewhere in that Chiang Mai campus, there's a building we in there. And we, a dot, right? ปิดไง ปะ right click เมาส์นี่ทำไง right click ไม่มีที่ปิดเหรอ Okay, good. Okay. You know the solar system, right? มีพระอาทิตย์มีโลกมีพระจันทร์ ไม่มีพระจันทร์มีโลกอังคาร Jupiter. Somewhere in here is what's the name? Huh? Milky Way. เป็นจักรวาลที่เราอยู่ จุดเล็กๆที่นี่ก็คือ solar system ซึ่งมีพระอาทิตย์มีโลกมีอังคาร You get some picture? Still we are nobody in the solar system. Last one. This picture they call deep field. That means เป็นจักรวาลแต่มี universe ต่างๆ เพราะนั้นผมอยากให้ทุกคนเข้าใจว่าก็เหมือนกบอยู่ในกะลาหรือกบอยู่ในสระกบก็นึกว่าสระนี่เป็นโลกความจริงแล้วโลกที่เราอยู่ก็คือ one atom of the whole universe. How we going to change our thinking? Our thinking is we want you to be humble that there's so many things that out there in the universe or in the world that you can go there and explore and learn. So this is a golden opportunity for you to go out there in the real world to learn. Wherever you are right now today, if you think it's so big, it's nothing. Quick one, sorry. I don't want to use all your time. Maybe we go ahead and skip it. Okay, go ahead, Tom.
Okay, thank you, Dr. Somkit. Actually, today, we could call this an all Texas day. Everybody talking today is from Texas. And the first Texan to speak, oh, I have to tell you first, everyone in Texas is from somewhere else. Everybody who lives in Texas, their families, they immigrate to Texas, okay? So, our first Texan is Dr. Wanpen Vongpatanasin. She is actually from Bangkok, and she graduated medical school from Chulalongkorn in 1990. In 1991, she received an award from the American Thai physicians because she received the highest score on the FM GEMS exam in 1991, which is the exam that used to take to practice in the United States. So she got the highest score. She is currently an associate professor in internal medicine, division of hypertension at Southwestern Medical School in Dallas, Texas. So she's Texan. She is board certified in internal medicine. She's the PI on one NIH grant, which is a huge, huge honor. She is co-investigator on 2 other NIH grants. She has 31 refereed publications, I believe 5 book chapters, if I'm correct, has been invited to speak at many, many places. If I was a Thai physician, she would be my role model. So you need to be that one when you finish, okay? All right, she is going to talk to us this morning on cardiovascular disease. Dr. Wanpen.
Well, thank you very much for the kind introduction. But first of all, I have to say that the highest score that I got actually because of the benefit I attended the first USMOE, well, back then it was the FM GEMS workshop ever conducted in this country by Dr. Somkit. So I hope you can get the same benefit as I did and go on to do some great things. But anyway. So I'm gonna, I have prepared a lot of questions, but I'm gonna skip some so that we can get the benefit of reviewing a lot of topics today. Some of it is gonna be PowerPoint, some of it's not. Oops, somehow, I guess it doesn't, it gives us the answer already? Okay, it should be a beam in. Okay, maybe I clicked too fast. How do I go back? I think it keeps going forward. Oh, boy. Okay. Well, that's a slight complication. ตอนที่ทำมันเป็นแอนิเมชัน มันไม่เป็นแอนิเมชันมันให้คำตอบเลย Let's see. It should be an animation. อะไรคะ Yes.
CD, you put CD.
I'm sorry, CD?
Or memory stick?
Yes.
Okay. Can you put new memory stick?
Stop it.
Hard drive first. It will be quicker.
You think it's still lost? You will lost the beam in though?
Okay, check it.
Yeah.
Check the second slide.
Okay, it's still there.
Okay.
It should be okay.
Hard drive,
Yeah,
quick
but no answer. But if you copy it to the hard drive, it will be faster.
But you won't lose the.
No.
Okay.
Should วย copy นั้นไป hard drive อันใหม่โอเค
ตอนนี้มันก็ work นะคะ
โอเค
ตอนนี้มันก็ work
Go ahead,
โอเค
go
ไม่
ahead.
เป็นไรค่ะ
Sorry
It's not very high tech slides. Okay, forget about the answer. Hopefully, that you saw, you might already remember. So, first question is: a 50-year-old woman presents with a chief complaint of dizziness when she gets out of bed in the morning. During the episodes of dizziness, she feels warm and flush. She admits to the frequent episodes of abdominal cramping and severe watery diarrhea during the past year, and then she started to have dry, itchy skin. On physical exam, she had a grade 2 or 6 systolic or murmur, best heard at the left lower sternal border. No wheezing, rhonchi, or crackles are apparent on lung examination. Laboratory results are unremarkable. Which of the following is the most appropriate next step in diagnosis? So, this lady seems to have a multi-system complaint. She has diarrhea, abdominal cramp. She has a murmur that it's consistent with tricuspid regurgitation murmur, and so they wanted to know. So they wanted us to know already what the diagnosis is, and then order the test. So actually, in this case, it's actually consistent with the picture of diarrhea and abdominal cramping and tricuspid regurgitation murmur. You have to think about a tumor. It's called carcinoid tumor, and the product of the carcinoid tumor is serotonin. So the metabolite of serotonin is 5-hydroxyindoacetic acid. So the way you diagnose it to do a 24-hour urine for 5-HIAA. So to review it, it's carcinoid tumor. It's a rare tumor, but actually they like to ask about that for some reason. But it's a neuroendocrine tumor that releases serotonin, and usually serotonin is converted to less active metabolites in the liver. So if you have a tumor somewhere else, you're not going to have much symptoms, except if you have liver metastasis. So the serotonin will be less likely to be inactivated by the liver, and patient will have flushing diarrhea, and that's called carcinoid syndrome. And 50 to 60% of patients with carcinoid syndrome will have a valvular fibrosis, because serotonin can promote fibrosis in the right side of the heart. So they can get either tricuspid regurgitation or stenosis, or pulmonic valve regurgitation or stenosis, and patient will have symptoms of right-sided heart failure. And like we talked about, a 24-hour urine, 5-HIAA will be the way to diagnose this. A patient with mastocytosis can have similar presentation in terms of diarrhea and cramping and flushing, but they usually don't have valvular heart disease. And the product of that is histamine, not serotonin. Next question, a 30-year-old man present to emergency department with headache, with visual changes and palpitation. Blood pressure is high, 190 or 130, and tachycardic of 130 per minute. And normal respiration. The rest of physical exam is unremarkable except for clampiness of the hand and sweating of the face. And so they kind of give you the diagnosis already. The 24-hour urine for VMA and HbA is elevated. So they tell you that this patient has hypertension from pheochromocytoma. But they asked further that the patient notes that the endocrine problem has been very common in his family, and the patient is they asked if the patient is most likely to have increased risk of the following thyroid diseases: A. Graves, B. Hashimoto, C. Medullary carcinoma, D. multinodular goiter, and E. papillary carcinoma. Anyone want to say? Okay, I heard something like C, so you guys know about this. So it's a C. So just to real quickly, pheochromocytoma can be a sporadic case, or it could be familial cases. So it could be part of MEN 2A or B. Most of people in MEN 2A or B will have medullary thyroid carcinoma and pheochromocytoma, and 50%. The difference between 2A and 2B is 2A have hyperparathyroidism, but 2B doesn't have hyperparathyroid but have mucosal neuroma. Another familial pheo is von Hippel-Lindau. Pheo can be present in 25%, and that's associated with retinal angioma and cerebellar hemangioblastoma and renal cell cancer. Neurofibromatosis is also have pheo, but it's more rare. Next question is a 39-year-old man came to the emergency department with acute onset of shortness of breath, hemoptysis, and left-sided pruritic chest pain. His past medical history includes medication-controlled asthma, peptic ulcer disease, and recent onset of nephrotic syndrome, a blood pressure of 180 or 100, and pulse of 110. And respiration of 28 is high. So you try, when you look at vitals, you try to interpret at the same time, not just letting it go through your head. So this patient is a little hypertensive, tachycardic, breathing fast. Chest and lung exam are normal, and laboratory exam remarkable for just elevated lactate dehydrogenase of 300 units per liter. Sinus ECG shows sinus tachycardia with prominent S wave in lead 1, inversion of T wave and prominent Q wave in lead 3. Which of the following is the most likely cause of chest pain? Okay, so say it again. E. Okay, well you guys already know that's good. So, pulmonary embolism, which is although not as common here, but it's very, very common in the United States. So there will be lots of questions about pulmonary embolism. So just to review quickly the EKG manifestation of pulmonary embolism, sinus tachycardia is common, obviously not specific. Right T wave inversion in right pericardial leads is also very common, but again, not specific. The one that's considered to be specific is called S1QT-T3 pattern, which is prominent S wave in lead 1 and a low Q wave in 3, not pathological Q like MI, and T wave inversion in lead 3. Right bundle branch block can be present, but less common compared to the first two. Okay, we're going to do power vote on this one. A 47-year-old Brazilian immigrant presents with fatigue and dyspnea. He's been healthy for 10 years and denies cough, chills, or weight loss. Physical examination show no murmurs. The pulse and the rhythm are regular. S1 is normal, S2 is split. The split increases with inspiration and persists with expiration. Which of the following ECG findings is consistent with auscultatory findings in this patient? So they have a patient who present with shortness of breath, and there's a S2 that increases inspiration, which is normal, but still persists with expiration. So it's sort of like a widely split S2. And so they have to, this is a little tricky question, but they want to know what do you think is the EKG changes that can consistent with this finding. A, ST segment elevation in anterior leads. B, decreased PR interval. C, early repolarization. D, marked T wave inversion. And E, right bundle branch block. Let's do a power vote. All right. Oh, okay. You guys, most people get the right answer. So the right answer is the right bundle branch block. So what happened is when you have a right bundle branch block, you have a delay in activation of the right ventricle. So what happened is S2 component is A2 aortic component and pulmonic component. So when you have delay activation in right ventricle, the pulmonic valve closed a little later, so it's more wide split, but it's still increased with inspiration normally and decreased with expiration with just a wider split. And actually what this patient has, in case they ask, there might be more question that you, is what this patient have actually is Chagas disease. The key is Brazilian immigrant, so it's a common problem in South America and caused by a trypanosoma, Soma cruzi, which is transmitted by blood-sucking Bredovic or triotomin bug, and it can be transmitted by blood transfusion. Now the blood transfusion in the United States is screened for for Chagas disease. In the acute phase, patient will have just a mild febrile illness. It's non-specific. But in the chronic phase, some patient may be asymptomatic, but some patient may go on to have congestive heart failure. And on the chronic phase, you're not going to see the trypanosome in the blood. It just be a progressive destruction of the muscles or connective tissue. So the EKG, they can also develop thromboembolism from LV aneurysm and syncope from arrhythmia. So they will have right bundle branch block and left anterior fascicular block and ventricular tachycardia because of this reentrance circuit around the scar. And they might have also a AV block that require a pacemaker. Next question, due to a recent and sudden death of a rival college football player, a local university wishes to implement changes in its healthcare policies. The school is particularly concerned about the risk of sudden cardiac death in players with previously undiagnosed heart conditions. A pre-participation evaluation is to be performed on all of the school's athletes. Which of the following is considered the most cost-effective method of screening in young athletes at risk for sudden cardiac death? Let's have a power vote on this one if I could. I know I didn't, can we do that? Can we just have a power vote? Do power vote then? ได้ไหมคะ ถ้าไม่ได้ก็ไม่เป็นไร ถ้าไม่ได้โอเค Okay, so this one is actually a little tricky. Actually, in United States, the screening method is still a careful medical history and physical examination. In certain part of Italy, there's a more common condition that's called arrhythmogenic right ventricular dysplasia. So in that part of, some part of Europe, resting EKG is the first screening, or at least one of the first screening. But in the United States, the careful medical history and physical exam is still the one that's recommended by the most recent American Heart. Oops, is it coming? Okay, most recent American College of Cardiology and American Heart Association guidelines. So class 1 is mean that it's recommended. Class 2B is the usefulness is still not well accepted. So they recommend family history and physical examination, including family history of premature or sudden cardiac death, and with the evidence review, family history of cardiovascular disease, including cardiomyopathy, is still recommended. So not the exercise EKG. Next question, a 20-year-old male college student is participating in a New York City marathon and collapses 1/3 of the way through the race. He is a well-developed athletic man who frequently plays basketball and tennis. He has no past medical history except for a tonsillectomy at age 9. There were no symptoms before he collapsed to the ground and lost consciousness. The patient is immediately rushed to the nearest emergency room, but it's pronounced death on arrival. Which of the following is the most likely underlying cause of his sudden death? A, aortic stenosis. B, arrhythmogenic right ventricular dysplasia. This is a condition that I mentioned that in Italy it's very common. They have to do EKG first. C, coronary anomalies. D, hypertrophic cardiomyopathy. E, isolated left ventricular hypertrophy, and F, myocarditis. So what do you think? What do you think is, yeah, let's do some power vote. Okay, so it's a little spread out, but most people get it right. So the most common cause actually is hypertrophic cardiomyopathy. So just to review, causes of sudden cardiac death in the young athlete in the United States. It's about 30 to 40% is hypertrophic cardiomyopathy. The second most common cause is the congenital coronary anomalies, where the left coronary artery coming out from the right aortic cusp, and then it get compressed between the root of aorta and pulmonary artery, and during exertion they can have cardiac death. Myocarditis is the next common cause, and that arrhythmogenic right ventricular cardiomyopathy, and the rest is spread out. Coronary artery disease is still not very common in that the age, but we need to know about hypertrophic. They love to ask about that. Next question is, a 67-year-old man comes to a physician because of insomnia, irritability, palpitation for 3 months. He's taking amiodarone for cardiac arrhythmias, fluoxetine for depression, enalapril for hypertension. His blood pressure is 130 or 70, so it's okay. His pulse is okay, 90 and regular. Which of the following is the most appropriate next step? A, measurement of thyroxine TSH. B, administration of propranolol. C, referral for psychiatric consultation. D, substitution of antidepressant. E, substitution of antihypertensive drug. You want to shout it out? Most people do. Oh, we don't have to do it every one. That's okay. Well, you can leave it. We don't have to do it in every question, but that's okay. So you want to know A, okay, yes. So we have to know that amiodarone can cause thyroid problems and could be hyper or hypothyroid. So we have to, the symptoms that they describe is more consistent with hypothyroid. So measurement of thyroxine TSH would be appropriate. So just a quick review. Hypothyroid is more commonly associated with amiodarone because it's high iodine content. But in 3% of the time, hypothyroidism can occur. Other side effects that we should remember is they could have hepatic side effects, dermatologic side effect. Photosensitivity is common. Up to a third can have neurologic side effects. Pulmonary toxicity is, although not common at all, but it's a deadly side effect causing pulmonary fibrosis. Corneal deposit actually occur in everyone, but it's not causing any vision problem. But the optic neuritis, which occur in less than 1%, is the one that can cause blindness. 40-year-old woman comes to physician because of 6-month history of increasing respiratory difficulty that occurs during mild exercise, such as walking uphill. She's 165 centimeter tall, weighs 58 kilograms. She said that she lost 4 kilograms in the past 3 months. Her blood pressure is okay, 120 was 75, pulse of 85. Respiration rate is normal, 16. Lung exam reveals crackles at both bases and a diastolic murmur near the cardiac apex. The characteristic of the murmur change with patient's position. An echocardiogram reveals a solid mass that partially fills the left atrium, resulting in obstruction of the mitral flow. Which of the following is the most likely diagnosis? A, fibroelastoma. I think we're going to do power vote on this one. B, metastasis. C, mural thrombus. D, myxoma. And E, sarcoma. All right, well, I don't have to talk about that at all. Okay, you guys know about this already. So this is a myxoma. So it's not very common, but somehow they have a lot of questions on myxoma. So anything about solid tumor in the heart, if you don't know anything, just take myxoma first. It will be correct. So just to review, it's the most common benign cardiac tumor in adults, and usually originate from the septal surface of the left atrium. So this is a picture of echocardiogram. This is the interatrial septum. This is the left atrium. You can see partial view of the left ventricle here, and this is a mitral valve. So this tumor, it's attached to the interatrial septum, but it's bulging the left atrium, and some can be very large and going through mitral valve. And it can cause variable obstruction. So the key, the question that we just look at, they tells you a lot of stuff, but sometimes they just say that you have a murmur that vary with precision because the tumor can flopping in and out of the left ventricle. And the complication, it can cause thromboembolism. If you obstruct the mitral valve, it can cause pulmonary edema, hemoptysis. And sometimes could be a cause of weight loss and fever of unknown origin, just like in this patient has weight loss because of interleukin-6 production. And it could be part of familial syndrome. This is part of what we call lamb, like a low lamb sheep. So this is a kid with freckles, so its lamb is lentiges and atrial myxoma, so it could be part of that. So next question is 47-year-old. No, okay. 47-year-old woman comes to physician because she has had several episodes of severe chest pain that awoke her in early morning. She has no history of major physical illness or drug abuse, drinks alcohol only occasionally, and does not smoke. Her temperature is normal, blood pressure is okay, 126/78, pulse of 78, respiration 12, ECG show no abnormalities, and no further study is undertaken. Physician tells the patient that her pain is probably from psychological in origin. A few days later, a patient comes to the emergency department at 5 in the morning complaining of chest pain. ECG show a sinus rhythm with ST segment elevation. Patient is admitted and coronary angiography is performed, revealing no stenosis. Intravenous administration of agonovine during arteriogram triggers chest pain accompanied by ST elevation on ECG. Which of the following is the most likely diagnosis? A, myocardial infarction. B, Prince-Metal angina. C, psychological chest pain. D, stable angina. Or E, unstable angina. What do you guys think? Any clue? Okay. B, okay, yes, so it is a Prince-Metal angina. So Prince-Metal angina is actually a coronary vasospasm. The patient will have a chest pain that looks like coronary ischemia, but the key is it's occur mainly in the morning. No one knows why. Perhaps the sympathetic tone is the highest, but typically not during exertion, but mainly with emotional stress or early in the morning. And during chest pain, patient will have ST elevation, just like an MI. But patient has no obstructive coronary artery disease. It's just from spasm. And agonovine diagnosis is agonovine challenge. Or you can have patient take breathing fast, and it can provoke that too. The treatment is to give vasodilator, such as nitroglycerin, calcium channel blocker. Alpha blocker can be helpful, but avoid giving beta blocker alone. It is not treating the same as obstructive coronary artery disease, because you can have unopposed alpha adrenergic receptor mediated coronary vasoconstriction. So you treat with beta blocker alone, it can make it worse. Next question, a 21-year-old man is brought by his roommate to the emergency department because of abrupt onset of shortness of breath, mild chest pain, and sensation of rapid heartbeat. He has similar episodes in the past, which resolved with Valsalva or breath holding, and this time the Valsalva is not successful, and he's not taking any medication. ECG shows supraventricular tachycardia with a pulse of 200. Under ECG monitoring, gentle massage over the right carotid sinus is attempted, but attack does not cease. Which of the following is the most appropriate next step in management? A, massage more. B, giving lidocaine. C, procainamide. D, verapamil IV, or E, oral verapamil. Should be pretty easy, you guys. What do you think? D, okay. So you have to break the reentrance circuit. So usually we give adenosine, but verapamil could be also useful. And obviously, when your patient has acute attack, you want to give something that works fast. So next question, let's see. Okay. 38-year-old woman complaining of shortness of breath, sudden onset. In the morning, she's previously healthy, taking oral contraceptives, and she smokes daily, and she's appear anxious and breathing fast, 30 breaths per minute. Her pulse, she's tachycardic. Her blood pressure is okay. The rest of physical exam is unremarkable. Which of the following is the most appropriate initial step? A, aspirin, B, Coumadin, C, heparin, D, fluid, D, streptokinase. So what do you think? A, B, C, D. So the key is the oral contraceptives. C, okay, so C is, so this, they give a history of pulmonary embolism, that the risk factor from birth control pills, and she's at least hemodynamically stable in terms of blood pressure, so initial step will be to give heparin first. So just to review, quick review, so PE, you have to give heparin, and then you have to review if the patient is at high risk or not at high risk. High risk is defined as hypotension and right ventricular dysfunction by echocardiography. So if you're at high risk, you have to consider most of the time thinking about thrombolysis with TPA. But if you're not at high risk like this lady, you just give heparin and then start warfarin with the INR of 2 to 3 for 6 months. And if the PE is triggered by known cause like surgery, trauma, or oral contraceptive, and this lady, you can stop it if you can stop the oral contraceptives. But if there's idiopathic or there's a genetic abnormality in terms of hypocoagulable states, then it has to be continued indefinitely. Let's see, next question. A 45-year-old man present to physician because of episodes of fainting. The radial pulse is, well, I guess we can skip that. You already know, this is a case of a myxoma, so I think we're just gonna, so it's a mass, talking about any mass in echocardiogram, we'll just go to, they said, they asked which of the following the most likely location, we'll just say left atrium. Okay, next, 64-year-old man brought to the emergency department because of sudden onset of tearing chest pain that originated in the anterior chest and radiated to the back in the interscapular region. A few weeks ago, he has a dental abscess, which resolved with extraction followed by a full course of ampicillin. On examination, he's oriented to place, time, and person. However, he appears in acute distress, diaphoretic, and breathing with difficulties. His temperature is okay, blood pressure is on the high side, and wide pulse pressure, 174 was 68. It's very tachycardic at 206 beats per minute. He's breathing fast, 25 per minute. No jugular venous distension or hepatomegaly. Auscultation reveals a diastolic murmur at the left sternal border. The lungs are clear to auscultation. No, ECG show no signs of myocardial ischemia. Chest X-ray show widening of mediastinum. Which of the following is the most likely diagnosis? A, aortic dissection, B, acute mediastinitis, C, pericarditis, D, cardiac tamponade, or E, myocardial infarction. What do you guys think? A, okay. So the key is widening of mediastinum, but beware, that could be from mediastinitis too. But the thing is that this patient has aortic regurgitation murmur, a diastolic murmur, and a wide pulse pressure. That could be a complication of aortic dissection if the dissection go back retrogradely to involving one of aortic cusps, so it could make the aortic valve not coapting and cause aortic regurgitation. So the answer is A. 56-year-old woman with long history of untreated hypertension, brought to emergency department because of headache and confusion. She's oriented to the person, but not to time and place. Her blood pressure is 230, 140, pulse of 86, respiration of 18. Fundoscopic exam showed optic disc edema. Dipstick showed protein in urine. Which of the following is the most appropriate pharmacotherapy? There are a lot of choices. Clonidine, enalaprilat. So it's enalapril in the IV form. Esmolol, furosemide, hydralazine, nifedipine, nitroglycerin, or sodium nitroprusside. So what do you guys think? Let me see. So esmolol, the answer is H, but esmolol can be used in some patients with aortic dissection. That's to prevent further, to reduce the shear stress. And nitroglycerin can be helpful in patients with coronary ischemia, but this patient they didn't tell you anything about she has hypertensive emergency because she has papilledema and very high blood pressure, but they didn't tell you about coronary ischemia or anything else. So the treatment will be H. Let's see. 72-year-old man comes in with pleuritic chest pain on 7th post-operative day after surgical pinning of intertrochanteric hip fracture. He was not on anticoagulants at the time. He's hemodynamically stable, but is short of breath and has distended neck veins. Spiral CT showed presence of pulmonary emboli on the left side. Echo showed no signs of right ventricular strain. What's the treatment? We just reviewed that. So this will be heparin, right? We talk about. So they just tell you up front has pulmonary emboli, but no RV strain, no normal blood pressure, hemodynamically stable. So you give heparin. And one thing to be concerned about after post-surgery is bleeding. So, but this patient already 7 days post-operatively, so the risk of bleeding is minimal or none. So treatment will be heparin. A thrombolytic agent will still be contraindicated in recent surgery. Okay. All right. Next question. Previously healthy 22-year-old man presents with progressive exertional dyspnea and also has precordial chest pain. His father and one of his elder siblings died of chronic heart disease in middle age. On exam, there's a loud S4 and a harsh systolic murmur. Murmur increases with Valsalva and decreases with squatting. There's a bibasilar crackles on lung exam. Blood pressure, pulse rate, and heart rate are within normal limits. Chest X-ray, no change in cardiac silhouette. EKG show left axis deviation. Echo show marked thickening of the interventricular septum with delayed relaxation and filling of the left ventricle in diastole. Which of the following is the most appropriate initial step in management? A, beta blocker, B, digitalis, C, long-acting nitrates, D, aortic valve replacement, E, partial excision of myocardial septum. Okay, let's do a power vote. All right. So this patient actually have hypertrophic cardiomyopathy. So there's a family history of heart disease. The murmur is characteristic in that it's a murmur that increases Valsalva. Anything that shrink the volume of the left ventricle will exaggerate obstruction in the left ventricular outflow tract. So the murmur usually louder when you squat. There's more venous return, so the volume, LV volume increases, the obstruction is less. So the treatment actually is a beta blocker. And just to a quick review, so it's a familial cardiac malformation that is due to mutations of sarcomeric genes. There are several genes involved. This is a pathology that shows this interventricular septum. The right ventricle is a tiny structure here, and this is a left ventricular free wall. So you can see a massive hypertrophy of interventricular septum. This is a left atrium, a mitral valve, and this is the aorta, and this narrow tunnel here is the left ventricular outflow tract. So the obstruction is not at the aortic valve, it's below the valve, at the left ventricular outflow tract. And the treatment, the initial treatment will be anything that decrease inotropic, decrease contraction, because the more vigorous contraction of the heart, the more turbulence and the more narrowing of this left ventricular outflow tract. So the treatment will be beta blocker or verapamil. Avoid excessive volume depletion, because that's shrink the LV volume and more narrowing here. Nitrates also try to avoid that and avoid digoxin. And some patient who continue to have symptoms despite beta blocker, verapamil, or some people use disopyramide, then you can consider a septal myectomy, so surgeon will take part some of the meat here. And now all they can do, there's a new procedure that you can do embolization of the septal arteries to cause myocardial infarction in this area, and then you can open up the left ventricular outflow tract a little bit more. Next question, a 74-year-old woman became delirious 1 hour ago. She was well until 5 days ago. When she tripped and injured her right leg, becomes bedridden since then. On exam, her temperature is okay. Blood pressure, it's within normal range. She's tachycardic and she's breathing fast. Heart-lung exams are normal, no focal deficit. Passive flexion of the right hip show obvious pain. Pulse oximetry show oxygen saturation of 80%. ECG shows sinus tachycardia. What's the diagnosis? That should be cerebral hemorrhage, cerebral infarction, myocardial infarction, pulmonary infarction, or pulmonary thromboembolism. Right, so that should be pretty easy. So it's a lot of PE question. They love that because this patient break her hip, and then immobility that promotes blood clots. So that's what she has, pulmonary embolism. She has hypoxemia. All right, 46-year-old woman complains of dyspnea on exertion and orthopnea. Starts 7 months ago. She has history of pericarditis. Is treated with indomethacin, and ECG now show low voltage in the limb leads. Chest X-ray show pericardial calcification. Echocardiogram show pericardial thickening. Cardiac catheterization reveals equal pressure in the 4 cardiac chambers. During diastole, with all pressure elevated. Which were the following findings on her physical examination would be consistent with a diagnosis of constrictive pericarditis? So, I mean, they actually tell you a lot of stuff, but they already give you a diagnosis of constrictive pericarditis. They wanted to know which of the examination is consistent with that. A, distended neck vein on inspiration. B, exaggerated first and second heart sound. C, extra third heart sound. D, extra fourth heart sound. E, predominance of left-sided symptom over the right-sided symptom. Okay, I think we're going to do power vote this one. All right, most people get it correct. So the answer is A. This is called, what do you call this sign? This increased neck vein distension on inspiration. It's called Kussmaul sign. So these are the signs of constrictive pericarditis. You can have just elevated neck vein with rapidly collapsing wide descent, or you can have inspiratory increase in jugular venous pressure, and that's because when you take a breath in, there's an increase in venous return to the right side of the heart. But the right side of the heart cannot dilate because of the scar encasing the heart. So what will happen is just a more increase in jugular venous pressure when you take a breath. There could be what we call a pericardial knock. It's a low frequency diastolic sound. It's what we call an early S3. It's following S2, but earlier than S3. You can patient mostly have hepatomegaly, more right-sided symptom than the left-sided symptom, and the heart sound should be decreased, not increased, like one of the choices. So next case, a 73-year-old man who comes with the chief complaint of fainting in the past 3 months, and he relates episode of left-sided chest pain that occur with exertion and resolve with rest. He's noticed increasing leg edema and orthopnea. No prior cardiac history and not taking any medication. Blood pressure is okay, pulse is okay. There's a pitting edema in both legs. Carotid upstroke is delayed. It's the key findings. Cardiac exam is remarkable for normal S1 and soft single S2. So heart late peaking systolic ejection murmur heard in the left on the right upper sternal border. ECG showed left ventricular hypertrophy. Which of the following is the most likely diagnosis? A, aortic insufficiency, B, aortic stenosis, mitral insufficiency, mitral stenosis, or tricuspid insufficiency? What do you think? Can you? So this is a patient present with heart failure, so there's an edema, but the carotid upstroke is delayed. So actually, that's the key finding of aortic stenosis. And the one of the physical exam signs of aortic stenosis is pulvus and tardus. So it's small volume and delay upstroke. And another exam that's consistent with severe AS is the late peaking. The early peaking, it's mild, but late peaking is consistent with severe AS, so the answer is B. 46-year-old man comes to medical attention because of dyspnea on exertion over 6 months. His blood pressure is okay, pulse is on the high side, 106 beats per minute. Respiration is normal. Patient has radiation therapy for mediastinal neoplasm 10 years ago. Liver is palpable at 3 centimeters below the right costal margin. Heart sounds are decreased, and jugular vein are distended, particularly during inspiration. So what does this patient have? We just talked about that a couple of slides ago. Constrictive pericarditis, right? So has risk factor for radiation, has a more predominant right-sided symptoms and decreased heart sound and Kussmaul sign here. Anyway, so you can already answer this. It's constrictive pericarditis, D. Let's see. 46-year-old woman come with chief complaint of chest pain on inspiration. The pain is on the left side, but lessen when she sits up and leans forward. So that's a key symptoms. History of renal failure on dialysis 3 times a week, but she missed the last 4 appointments. Auscultation, there's a scratchy leathery sound in both systole and diastole. ECG showed diffuse ST segment elevation and PR segment depression. QRS amplitude is low. Which of the following is the most appropriate next step in management? Beta blocker, morphine, non-steroidal, nitroglycerin, non-steroidal, or steroids. So what this patient have? The pain is characteristic of lessen when they sit up and leans forward. That's the pain of pericarditis, and the sound of physical sign that this is consistent with pericarditis as well. So the treatment would be, say it again? Non-steroidals. Usually steroid can help reduce inflammation, but you have more recurrence afterwards. Other treatment that could be useful is colchicine, but in this question, there's no choice in that, so we'll just say non-steroidal. Okay, they'd like to ask this type of question too. Routine medical checkup, 18-year-old man is found to have mid-systolic click, followed by a murmur. He's 195 centimeter tall, arm span is 205 centimeter. He weighs 80 kilograms. Examination show pectus excavatum and the bossing of frontal eminences with the laxity of the ligaments. The thumb can be extended to the wrist. And he says that his dad died at the age of 40 because of heart problems. Which of the following is most likely diagnosis? A. Ehlers-Danlos syndrome, B. Klinefelter, C. Marfan syndrome, D. McCune-Albright, or E. osteogenesis imperfecta. C. Okay, that should be on. So the mid-systolic click followed by a murmur that is from mitral valve prolapse. And, so this patient has Marfan syndrome. Okay, 35-year-old non-smoking woman has dyspnea, fatigue on exertion, and a chest pain. She has no history of thromboembolic disease or rheumatic heart disease. Examination show increased jugular venous pressure, a left parasternal heave, accentuation of P2, and a decrease in carotid pulse. So exam is consistent with pulmonary hypertension. No murmurs are present, breath sounds are normal. Laboratory findings show hypoxemia and normal PaCO2 and polycythemia. Dilatation of right and left main stem pulmonary artery and clear lung fields are noted on chest X-ray. ECG show a right axis deviation and right ventricular hypertrophy. Which of the following is the most likely diagnosis? A. Mitral stenosis, B. COPD, C. Pickwickian, and D. Primary pulmonary hypertension. So a non-smoking woman, a young lady, non-smoker, no history of pulmonary emboli, but has evidence of pulmonary hypertension. D. So primary pulmonary hypertension is common in, she fits the profile of young woman with primary pulmonary hypertension. But other things we need to exclude is persons of connective tissue disease like lupus can cause that before you can call someone primary pulmonary hypertension. This should be quick. So what do you think is the diagnosis? 65-year-old man with ischemic heart disease and with this EKG. PAC, atrial flutter, atrial tachycardia, V-tach, or sinus tach. It shouldn't be sinus tach, that's for sure. So what you see is a Y-complex tachycardia, right? Y-complex tachycardia. The rate is around 150 to 200. And this is a sinus beat. This is probably a sinus. There's a PVC here. And this Y-complex tachycardia looks like just like a PVC. So what do you think that is? So this is a ventricular tachycardia. So if you have more than 3 PVC looking in the row, 3 or more, then you call V-tach. The answer is D. Okay, I'm going to skip that one because they already talked about that in hypertension. Okay, let's talk about this one. 45-year-old male patient with the atrial rate, has an atrial rate of 300 beats per minute. and ventricular response with the 2-to-1 ratio. So only 2 atrial beats, all the ventricular beats capture only after 2 atrial beats. After treatment with an antiarrhythmic drug, atrial rate slowed down to 200 beats per minute, but ventricular rate increases to 200 beats per minute. So now it becomes 1-to-1, but the atrial rate slowed down. Which of the following drugs was most likely used? Adenosine, digoxin, propranolol, quinidine, or verapamil? Let's do a power vote. All right, let's see. Okay, so the answer actually is D. Remember that most of the drug here, digoxin, adenosine, verapamil, and propranolol, actually should slow down, should increase the ratio to greater to 3-to-1 or 4-to-1. The drug as quinidine, procainamide, disopyramide belong to class 1 antiarrhythmic drugs, specifically 1A, which block the sodium channel. And what will happen during that is it increased action potential duration in the atrium, so it actually slowed down the atrial rate, but in the same time it accelerated the AV conduction, so the atrial rate slowed down from 300 to 200, but increased accelerate AV conduction to 1-to-1, from 2-to-1 to 1-to-1. So the drug that can do that is the class 1A antiarrhythmic drugs, which blocks the sodium channel. 1B includes lidocaine, mexiletine, tokinine, 1C, propafenone, encanine, flecainide. Class 2 is beta blocker. Class 3 antiarrhythmic drugs is block the repolarizing potassium channel, such as sotalol and amiodarone. It does tons of other things too, but it's at least classified as class 3. And class 4 is calcium channel blocker. So in this case, so when you have this patient have atrial flutter, so before you give this type of drug, if you want to do it, you need to give a drug like digoxin, verapamil, or propranolol up front. Otherwise, the patient become more tachycardic, and it could be compromise the blood pressure. Okay, let's skip that one, I think. Let's see. Okay, I guess we can do this one. These potent arterial vasodilator are reserved for management of severe hypertension, and beta blocker are required to offset compensatory reflexes. The adverse effects profile includes marked postural hypotension, salt and water retention, angina, and hypertrichosis. They want to ask us to list 2 agents. So the choice are nimodipine, beryllium diazoxide, hydralazine, procainamide, minoxidil, nifedipine, prazosin, sotalol, and verapamil. So which drug do you think it could cause it? 2. And again. Just shout it out. Well, the drug that's mostly for sure that caused that minoxidil, the Rogaine, it caused increased hair, so that's one. And the other one that I don't know why they're still asking me, but diazoxide also can do that too, but I don't think it's even clinically available in the United States, but since it's in the question, then I just review it, I just show it. Let's see, okay, this is a little hard, but some with, this drug is associated with lupus-like syndrome with a prolonged treatment. The drug prolonged PR interval by blocking potassium channel during phase 3, repolarization of cardiac potential. They just want to ask, they ask only one. So the choice is still the same, nimodipine, beryllium diazoxide, hydralazine, procainamide, minoxidil, nifedipine, prazosin, sotalol, and verapamil. So lupus-like syndrome, but more than that, they want to know it has prolonged PR interval by blocking potassium channel in the phase 3. We talk about ability, just like a class 3 antiarrhythmic drugs. So actually, the only two choices we should know that can cause lupus-like syndrome is hydralazine and procainamide. If you don't know anything about which drug block potassium channel, you can look at prolonged PR interval. Usually hydralazine causes reflex tachycardia, so not likely it would do that. The drug that actually can do that is procainamide. Can cause both lupus-like syndrome. Although procainamide is a 1A agent, but it can also block potassium channel during phase 3 as well. Next question, a 28-year-old woman, gravida 1 para 0, 25 weeks, pregnant by date, shortly after birth. She has what was diagnosed with transposition of the great vessels and underwent corrective surgery, which was successful. She's married for 7 years, employed as an accountant, has no shortness of breath and dyspnea at rest. But when she walks from her car to her office, she has minor complaints. Based on the New York Heart Association functional class of heart disease in pregnancy, to which of the following classes would she be assigned? Class 0, 1, 2, 3, or 4. So actually, it's a tricky question. This one, there's no class 0. New York Heart Association doesn't have class 0. So class 1, there's no limitation with the normal activity. Class 2 is mild limitation, which this lady has, mild limitation, just walk from her car to the office. Marked limitation, like, is class 3, and class 4 is shortness of breath at rest. So just to, although it seems to be easy question, but you have to remember which class is it. Are we going to take a break?
Some kids say go ahead and just go through.
Go through them? Okay.
You want water or something?
No, I'm fine. Thank you. I have some. Okay. Just in case they feel tired and they want to rest, but we'll go through that. Okay. Let's see. I think I'm going to skip that one. People talk about hypertension already. Okay. Okay. 62-year-old man had myocardial infarction, taking a quart of aspirin daily and maintenance dose of Coumadin. This is probably an old question. I didn't give you INR, but prothrombin time of 11 to 15 seconds. While on vacation, he's taking over-the-counter cimetidine for acid indigestion. A day or two before returning home, he develops UTI, for which he was treated with trimethoprim sulfamethoxazole. And when he comes back home, his prothrombin time doubles, increased by more than double, actually. Which of the following statement about this situation is most accurate? A, the dose of warfarin should be increased to ensure adequate anticoagulation. B, antibiotics have increased the activity of the liver enzyme that metabolize warfarin. C, antiplatelet action of aspirin block effects of warfarin. And D, cimetidine inhibit hepatic metabolism of warfarin. So what do you guys think? So for sure, A, it doesn't sound right. I mean, the prothrombin time has already increased more than twice, so there's no sense of going up more than they have risk of bleeding. Antiplatelet action block, there's no such a thing of antiplatelet action blocks effects of warfarin. Everything is potentiate bleeding risk of warfarin. So it's either B or D. Most of the time, antibiotics doesn't really increase activity of the enzyme. It may decrease vitamin K dependent clotting factors, but usually doesn't have any effects on the liver enzyme that metabolize warfarin. So if you don't know anything, by exclusion, D should be the most correct. And that's the answer. So just quick review, there's a last thing that can potentiate action of warfarin through different mechanism. The drug to remember is like trimethoprim, sulfamethoxazole can increase the prothrombin time associated with warfarin. Isoniazid, fluconazole, erythromycin, amiodarone, propafenone, anti-inflammatory drugs can just potentiate it because of anti-platelet effects, not through metabolism of warfarin itself. Cimetidine can inhibit the enzyme that in the liver that converts warfarin to less active metabolites, so it can prolong prothrombin time as well. Rifampin can increase activity of the enzyme that metabolite warfarin, so it can inhibit effects of warfarin. And these are the rest of it. And obviously high vitamin content in the food can inhibit effects of warfarin as well. Let's see, okay. So that 55-year-old African-American man with 5-year history of hypertension, retinal exams show irregular caliber of arterioles with copper wiring and focal areas of AV nicking, no flame-shaped hemorrhage or exudates are present. Which of the following is most likely diagnosis? A, normal retina. B, grade 1. Can be normal, for sure. Grade 1, grade 2, grade 3 or 4 hypertensive retinopathy. So 4 usually sounds like there has to be papilledema. So either 1, 2, or 3. So this patient actually has grade 2. Just to quickly review. So normal, obviously there shouldn't be any copper wiring or silver wiring or papilledema. The normal arterioles to venous ratio should be about 3 to 4. Grade 1, the arterioles start to narrow, so the ratio decreases from 3/4 to a half of the size. And still no copper wiring or silver wiring. A little bit more depression of a venous when the arterial venous are crossed. But grade 3, there's further narrowing of arterioles, but now start to have copper wiring appearance and more depression. There's more AV nicking. Grade 3, that's where you start to have hemorrhage and exudate and silver wiring. But grade 4 is the one that has papilledema. So that's why the answer is 2. 65-year-old man with multiple myeloma presents with confusion, depression, and vomiting polyuria. Before you even look at EKG, what causes confusion, depression, vomiting, polyuria, and multiple myeloma? You have to think about what causes that. Well, anyway, look at the EKG anyway. Electrocardiogram follows, show here. And what's the first step in management? So you have to know what is the cause of this EKG, or what's the abnormality in the EKG first. So this patient has a little bit of leftward axis, but normal sinus rhythm. QRS is normal, but what about ST changes? So one thing to think about, patients with multiple myeloma, they have hypocalcemia, right? So they have less ability to concentrate urine. So what's the EKG manifestation of hypocalcemia? What this patient has is what they call a shortened QT. It's the opposite from oops, I'm not finished yet. Okay, so it's a shortened QT interval. The onset of Q wave to the end of T wave is shorter. It's opposite from prolonged QT, but it's a shortened QT interval. So the treatment of this condition is, obviously you don't want to give any more calcium. Sodium bicarbonate, that's more for hyperkalemia. And you want to avoid volume depletion because that tends to exacerbate hypocalcemia. So the initial treatment will be to give fluid, intravenous saline, and in some patients who are resistant to that, then there might be a role of that, mitomycin. So infuse saline. Sometimes when there's EKG that you don't know what it is, go back to read what's the condition of the patient first, and then sometimes you can guess what it is if you don't know what the EKG show. Okay, this one is important too. A 60-year-old man complains of pain and numbness in the left leg when walking. Pain is relieved by rest, and he also has impotence. Physical exams show atrophy of the left leg, normal reflexes, and a bruit over the femoral artery. Which of the following is most likely diagnosis? Actually, if you don't even know the name of this condition, you can guess it. So what caused a bruit over the femoral artery? So patient has atherosclerosis, right? You have to have atherosclerosis. And so he has evidence of peripheral arterial disease. So that's explained the claudication when he walks. But in the conjunction, the impotence, there's an acronym for that. It's called the Rich syndrome, which is an occlusion in the distal aorta and or the origin of iliac arteries. So that causes both intermittent claudication and impotence. So when you already hear bruit, if you don't know what the Rich syndrome is, you can guess that a bruit probably wouldn't be associated with lumbar disc or osteoarthritis. Peripheral neuropathy shouldn't have a bruit either. And this one is more, it's not a vascular disease. I guess it could be a problem if you don't know what that is. But here is the Rich syndrome. Okay. I think I'm going to skip that. So this is just the EKG of hyperkalemia. You can see a peak T waves. I don't want to go into detail, but anyway, this is hyperkalemia. And they asked about what are the drugs that can reverse effects of hyperkalemia. And the answer would be calcium gluconate. Okay, I'm just going to skip that too. 58-year-old man with palpitation and lightheadedness with this EKG. Which of the following is the most likely problem associated with this parent? A, congenital heart disease, B, severe aortic valve disease, C, hypokalemia, D, atrial septal defect, or E, ventricular septal defect. So let's go through that. So the axis is okay, and the P wave looks all right, the PR interval looks okay. What do you think about QRS? It's a little widened. It's a little widened. Probably right at 3 boxes. And the notable thing is you can see RS prom in the left precaudal leads V5 or 6. So it's more like a left bundle branch block type of pattern. So which are the following choices associated with more likely to be a left bundle parent? So congenital heart disease is very non-specific. So I mean, depending on, so it's not likely to be the answer because you have to have, it can be involved the left ventricle or right ventricle. So the answer actually is severe aortic valve disease. That can initially cause left ventricular hypertrophy, but as time goes on, you might have conduction system disturbance in the left ventricle. Hypokalemia, it mainly affects the QT interval, so it's not a feature. Atrial septal defect usually causes right bundle branch block, not the left bundle branch block. And VSD, you can have biventricular hypertrophy, but this is more on the left-sided, so the answer is aortic valve disease. What metabolic abnormality is typical cause of this EKG? A, hypokalemia, B, hypocalcemia, C, hypomagnesemia, D, hypokalemia, or E, hypocalcemia. So they didn't show all the 12 leads. So just to orient you, this is a V2, and up here, that's the beginning of V5. V3 is here, and this is like a continuous strip of some sort. They didn't label what it is. So the QRS looks normal. There's a T wave, and there's another wave, big wave after that. What do you think that is? Actually, this is a U wave. So one could ask, why couldn't it be a P wave? This is actually a tricky EKG. You look at the 12 lead, it's irregular, so this patient has atrial fibrillation, so you don't see a P wave. But the one that followed the T wave is actually a prominent U wave, and that's signs of hypokalemia. Okay, I think I'm going to pass through that. Okay. A positive ECG exercise test for diagnosis of coronary artery disease should show A, tachycardia, B, bradycardia, C, 1 millimeter flat or downsloping ST segment depression, D, normal EKG. That, you know, that can't be a normal EKG if you have positive tests, right? Otherwise, why bother? E, absence of U wave. So what is the answer? C, so it's pretty easy. The key is not any type of ST depression is normal. The one is flat or downsloping. When usually what you have to look at is the J junction can be depressed, but 60 to 80 milliseconds after the J point, normal EKG, it should be upsloping, it should go back to baseline. But if it's 60 milliseconds past the J point, it's still 1 millimeter or more depressed and doesn't return to baseline. What is called is PQ segment. That's considered to be abnormal. Okay, I think we're going to do power vote on this one. On what basis can diagnosis of malignant hypertension be made? A, systolic blood pressure. B, diastolic blood pressure. C, headache. D, fundoscopic changes. Or E, heart size. Let's do a vote. All right, good. Everyone got it. So malignant hypertension not just determined based on the level of blood pressure, because adult with blood pressure of 200 or 100 might not feel anything. It's just severe hypertension, but not hypertensive emergency. On the other hand, a kid with acute glomerulonephritis may have a hypertensive emergency with a blood pressure of 160 or 100. So it depends on rapidity. And the key is what we call acute target organ damage. So if you have papilledema, that's consistent with acute target organ damage. Heart size, it's more like a chronic organ damage, like ventricular hypertrophy. It doesn't consider to be malignant hypertension. Headache, without intracranial bleeding or swelling, then you can't call it malignant hypertension either. Okay. Which of the following findings in physical examination are compatible with cardiac angina? A rise in blood pressure or pulse rate. B, audible or palpable forced heart sound. C, increase in angina pain after a Levine test. D, appearance of murmur of mitral regurgitation. D, paradoxical splitting of the second heart sound. So what do you guys think? When patient have angina, what could they have? A, B, C, D, or E? Let's do a vote on that too. Would that be okay? Sorry. Are we doing power vote on that one? That's okay, that's okay. I thought you heard it. So you want to shout it out, which one? C? Anyone say C? Okay. Well, there's no Levine test, really. There's a Levine sign, but it's not a Levine test. It's tricky, Levine signs. Oh, I have chest pain, but there's no Levine test. Actually, the audible, palpable fourth heart sound is a sign of angina because fourth heart sound, it indicates decrease in compliance of left ventricle. So cardiac ischemia can cause decreased compliance of the left ventricle, and then that can cause fourth heart sound. So the answer is B. Appearance of mitral regurgitation, if you have a anterior MI that causes papillary muscle, inferior wall MI that causes papillary muscle ischemia, you can have mitral regurgitation, but this is just angina, not myocardial infarction. What caused paradoxical splitting of the second heart sound? Anyone know? Paradoxical splitting of the second heart sound? That means that when you take a breath in, the A2, P2 get narrower, and then when you breath out, it gets wider. It's different from widely split. This is a paradoxical split. That's a sign of severe aortic stenosis because there's a delay in ejection of left ventricle. So when you take a breath in, the A2 is more delayed, but it's getting closer with P2. So that's caused it's a severe sign of severe AS. Okay. Mitral valve prolapse can be described by which of the following statement? A, most affected individuals are asymptomatic. B, men are affected more often than women. C, ventricular arrhythmia are common. D, mitral regurgitation frequently develops. Or E, congestive heart failure frequently develops. So what do you guys think? They asked a few questions about mitral valve prolapse too. So mitral valve prolapse is actually very common that the patient doesn't feel anything, just incidental findings. So most patients are asymptomatic and usually involve women than men. Arrhythmia can occur, but it's rare, and usually patient doesn't have severe mitral regurgitation. They might have signs of MR, but usually MR is not severe, or it might not occur at all. And CHF is not very commonly occur. Okay, we can go through this too. So they asked us to choose the choice of A, B, C, D, E based on the description of each type of valvular heart disease. What could be a complication of inferior wall MI? So aortic stenosis, mitral stenosis, aortic regurgitation, tricuspid regurgitation, or hypertrophic cardiomyopathy. Same thing, idiopathic hypertrophic. That's an older term. Maybe a complication of inferior myocardial infarction. So just usually mechanical complication of myocardial infarction usually cause regurgitation. Stenosis is just, you can just throw it out. So it's either aortic regurgitation or tricuspid regurgitation, right? Because hypertrophic cardiomyopathy is a familial syndrome. So either AI or tricuspid regurgitation. So what do you think is a C or a D? It's D, because inferior wall myocardial infarction usually is a result of occlusion of the right coronary artery, which also supply the right ventricle. So if you have massive right ventricular infarction, then it can cause right ventricular dilatation and tricuspid regurgitation. So that's the D. Associated with the largest degree of left ventricular thickening. That's a little tricky. So to have a left ventricular thickening, it has to involve the left side of the heart. So aortic stenosis, mitral stenosis, aortic regurgitation, so tricuspid shouldn't be a cause, or idiopathic hypertrophic cardiomyopathy. So mitral stenosis, usually it causes a small heart because you have decrease in stroke volume, decreased filling of the left ventricle. So it's either aortic stenosis, aortic regurgitation, or hypertrophic cardiomyopathy. So it's either A, C, or E. What do you think? A, C, or E. So actually, this one is a little tricky. It's actually a C. Because aortic stenosis is a pressure overload, but aortic regurgitation is both pressure and volume overload. So it actually have the largest heart. They call pathology call it cor bovinum, or the cow's heart. So human heart looks like a cow's heart in the aortic regurgitation. Atrial arrhythmias and recurrent pulmonary embolism are fear complications. So this should not be as bad. So one of these should have what caused atrial arrhythmia the most. So what caused AFib among these atrial fibrillation among these choices? Should be a mitral stenosis, right? Because it impedes the emptying of left atrium, and that usually causes massive atrium dilatation and atrial fibrillation, and sometimes it involves the right atrium, so the blood clot can form on the right side as well, and it can cause pulmonary embolism. But more likely systemic embolism is the complication. But atrial arrhythmia, then you should think about mitral stenosis. Loudness of the murmur can be misleading in severe cases. This may be a little difficult, but aortic stenosis, sometimes with severe AS, might not have a loud murmur. They're more likely to have a later peaking, so you might perceive it as not as severe. So the answer is aortic stenosis. Okay, I think this one you should know. Okay, I'm going to skip that too. Okay, this one I think is pretty hard. It could be a cardiology board exam, but they have in USMLE, so let's talk about it. 71-year-old male presents with cardiogenic shock and acute pulmonary edema. 9 years earlier, he had both mitral and aortic valve replaced with Bjork-Schiley prosthesis. It's a mechanical valve, so it could be this is a question about prosthetic heart valves, which could be a tissue valve or bioprosthesis or mechanical valve, but Bjork-Schiley is one of the mechanical heart valves. And a frame from Sydney fluoroscopy study shown in this figure demonstrate all of the following except. So it's not very good picture, I tried, but anyway. So choices are intact aortic valve prosthesis, B, mitral valve prosthesis, C, several minor strut, D, free floating disc. So this is the middle part here is the spine. You can see the spine here, and there's a disc here. And you can see couple of structure. One is it looks like a line here, which is actually a valve that you look at on the side, like looking at a ring on the side. And this is another valve that you look at it on the front. You look at it on face to face. And there's a couple arrows. There's another arrow here. There's a little thing here that obviously not a normal structure in normal human beings. And there's another oval shaped thing here. So something bad happened. Obviously, patient had cardiogenic shock and acute pulmonary edema, and there has to be a mechanical valve complication. So one of these valves must be disrupted. So the question is it the aortic valve or mitral valve? So usually, if you look at the X-ray face-to-face, the aortic valve, you usually look at the aortic valve on the side. So this actually is aortic valve. And mitral valve is more aortic valve is superior orientation. The mitral valve is a little bit more orientation that is more like this. So what will happen is, so this aortic valve is okay, but then the mitral valve is broken. And so they're asking what is not correct. So the answer is B, mitral valve is disrupted, just to show you what a normal valve on X-ray should look like. Bjork-Shiley, it should have a major strut and a minor strut and have a disc in the middle. So this one is a minor strut that falls off, and the discs that come out fly out from the valve. And so when it occurs acutely, it can cause acute pulmonary edema. It used to be one of the most common valve replaced in the United States until 1986 when the valve started to break. So patient can have acute onset of dyspnea, loss of consciousness, cardiovascular collapse, and severe valvular regurgitation depending on which valve the prosthesis is implanted. Okay. Which of the following has not been implicated as clinical complication of sleep apnea? A, left heart failure, B, pulmonary hypertension, C, behavioral disorders, D, systemic hypotension, E, nocturnal death. Let's do a power vote. This one. Talk about sleep apnea complication. Oh, can we redo it or no? Guess no one wants to answer, or then you don't know? Are we going too fast, or can we redo it? I guess no one pushed the button or somehow. Can't be 100% Eric. Okay, let's do it again. Wake up. They asked, which of the following is not a complication of sleep apnea? Oops. Uh-oh. Okay, good. Okay, let's vote. Let's not make it 0. All right, good. So at least half of the people here know. So all of these, usually it causes hypertension, not systemic hypotension. It's a complication of sleep apnea. And heart failure, pulmonary hypertension is a known complication. Behavioral disorder can happen if patient has daytime sleepiness because they can't sleep at night. So that's the cause of, they can have decrease in attention, and it can actually happen in kids, so they might not be able to attend the school well. They can fall asleep at work, and so that could be, and it can cause sudden cardiac death at night because it's associated with arrhythmia. So just a quick review, sleep apnea can cause nocturnal hypoxia that stimulates the chemoreceptor, and that can cause activation of sympathetic nervous system, and that can cause release of norepinephrine to the blood vessels, and it causes vasoconstriction and hypertension. Initially, it might occur only at night, but if you have repetitive stimulation, over time you can have sustained hypertension. And it's a common cause of resistant hypertension, particularly in obese individuals. You should think about that. And it could be improved. Blood pressure can improve with weight loss and nocturnal CPAP. All right. Let's see. Okay, 35-year-old man brought to the office because of progressive worsening heart failure. He has history of hypertrophic cardiomyopathy, but now he has ejection fraction of 25%. So initially, people with hypertrophic cardiomyopathy can have normal or supernormal ejection fraction, but over time, the fibrosis can take over and they can have progressive heart failure and reduce ejection fraction. His creatinine is 2.5 BU and is 36. He has 2+ pitting edema. His renal function is worse, and diuretics and cardiotropic agents are now not helping him. You recommend A, renal dialysis, B, a kidney transplant, C, cardiac cath, D, renal biopsy, or E, a heart transplant. So what do you think it should do in a patient with severe heart failure and now with renal failure, despite all the drugs? Relatively young man. Is it A, B, C, D, E? So one thing to consider, although we're starting to do it here, is to think about heart transplant. And the current indication for cardiac transplantation in the United States is patient with refractory cardiogenic shock, a patient who depends on intravenous inotropic support, such as dobutamine or miranon, to maintain adequate organ perfusion, peak oxygen uptake. So if you do a cardiopulmonary testing and the oxygen uptake is low, that usually means the ability of the heart to deliver oxygen is low, less than 10 mils per kilogram per minute. Severe symptom of ischemia that limit routine activities that's not amenable for bypass or percutaneous coronary intervention. So just on the basis of ischemic heart disease that is severe and that's not amenable for bypass or stent, you can get transplantation based on that indication. Patients who have recurrent arrhythmia despite all therapeutic modalities, although this is a less common indication now with the ICD and the electrophysiology ablation of the circuit is less common. But that he fits at least one of the, presumably this indication. All of the following are important in evaluation someone with appropriateness for the transplant, except wealth, compliance with medical regimen, alcoholism within the last 6 months, support network, or psychiatric evaluation. So what do you think? What are the, except to evaluate the appropriateness for heart transplant, what are the factors including to the consideration except? So in the United States, at least you're not supposed to exclude someone based on wealth. And compliance of regimen obviously is a key, important, because if they are not reliable in taking immunosuppressive drug, the transplant will be rejected, heart will be rejected. Substance abuse going along with compliance, and they have to have support network to help. And if they can be having psychiatric problem, obviously, because it will interfere with compliance. Okay, this patient admits drinking alcohol occasionally because of he's been nervous. He denies ever drinking more than 1 beer a day. You tell him you cannot get a transplant. You must stop drinking completely for at least 6 months. He must stop drinking and goes to Alcoholics Anonymous program. He is still eligible for transplant but should not drink anymore. You have to talk to a psychiatrist. This one is more like a common sense. This is occasional beer. So actually, I think this is wrong. It should be a D. No, I mean, 1 beer, less than a beer, you don't have to go to Alcoholics Anonymous. But anyway, that's one you should. It's a D, not the C. He's still eligible, but shouldn't drink anymore. Okay. Okay, I think I'm going to skip through this one too. Okay, 3 years later, okay, I'm just cutting the history, it's too long, but anyway, I just abbreviate. This is a patient with complaints of cramping, numbness, fatigue of the calves. Cannot walk normally. It's more severe on the right compared to the left. The breast pain, now he beginning to have pain at breast. And there's a decreased pulses on the femoral on the right and decreased dorsalis pedis and posterior tibialis on the left. There's the evidence of thickened nail beds and dry, cool, smooth, shiny skin with decreased hair bilaterally, as well as trace bilateral edema. Angiogram show here. You suggest of the possible option except a pentoxifillin, 100 milligram 3 times a day, percutaneous angioplasty, rotational atherectomy, intravascular stent, and aortofemoral bypass. So they describe a patient with intermittent claudication, which is now progressive to be pain at rest. And the exam that's consistent with ischemia of the limb, so dry, decreasing temperature, and there's a chronic ischemic changes that the hair, there's a decreased hair. And so what's the treatment except? So if you use common sense, you go from B to the E, it seems like there's a procedure of some sort, and A is a medical therapy. If you don't know anything about treatment of peripheral arterial disease, this kind of stand out. So the answer is A. And the reason the treatment of peripheral arterial disease can be presented as asymptomatic, just picked up by a non-invasive test. Or patient may have intermittent claudication, or patient might have evidence of pain at rest. It's called critical limb ischemia. So the patient is not symptomatic, just positive by screening test. You just do risk factor modification, stop smoking, control the cholesterol, control the blood sugar, control blood pressure, start some aspirin or antiplatelet clopidogrel. If your patient has intermittent claudication, you do a risk factor modification and then add exercise program. There's a program that allows patient to start increasing walking, and that can increase the walking time. And the symptoms is improved. The patient stay on medical therapy. If the symptom is still worse, then patient needs to have some sort of angiogram done, followed by revascularization procedure, either stent or surgery. If patient already have pain at rest, they have to intervene quickly to prevent the limb loss. So that's why medical therapy wouldn't be correct. And just to let you know, that's probably an old question, because now pentatoxifillin is not used for intermittent claudication. Now we use cilostazol, which is more effective in improved walking distance. Okay, I think I'm going to skip that one. Okay, this one is important. 62-year-old man with hypertension and congestive heart failure presents after a suicidal attempt. He's taken a bottle of digitalis pills. Which of the following possible arrhythmia all can be seen except? So we're talking about what are possible cardiac arrhythmia associated with digitalis toxicity. A first-degree AV block. B, third-degree heart block. C, multifocal atrial tachycardia. D, bidirectional ventricular tachycardia. E, all of the above can be seen. So what do you guys think? A, B, C, D, or E? So actually, digitalis, as we talked about, it can block the AV node. So it can cause either digitalis toxicity, it can cause either A or B, it can cause first, second degree, or third degree heart block. But the funny thing with digitalis toxicity is it increases automaticity in the both atrial tissue and ventricular tissue, so they can have the characteristic that you have multifocal atrial tachycardia with block. So it accelerates automaticity in the atrium. It can cause ventricular tachycardia as well. And the characteristic of ventricular tachycardia associated with the digitalis toxicity is called bidirectional tachycardia. It's called sometimes come from the left ventricle and sometimes from the right ventricle. So the answer is all of the above can be seen. Okay, this one is a little hard. Actually, it could be on cardiology boards, but they have it here. So they really like it. So this is they give you a pressure tracing. The top line is the EKG, and they're asking which of the following is not true. So just to orient you, this is the pressure here. So the grid is 200, 150 millimeter mercury, 150 and 0. And this is the left ventricular tracing. There's two catheters, one catheter is in the left ventricle, so they say LV here. So the left ventricle pressure, peak systolic pressure is a little bit more than 150 millimeter here, and then it dips down. Left ventricular and diastolic pressure usually is low. And then this is the second line called A here is aortic pressure. So aortic pressure in this patient is the systolic pressure in the aortic catheter is about 125, and this is a little below 50. So the aortic pressure should be similar to a systemic blood pressure like we measure in the arm. So this patient aortic pressure is about 125 over 50, something like that. But the left ventricular pressure, you can see, is a little bit more. The systolic is a little bit more. So the first two beat is a normal sinus, and there's a PVC, and then followed by a normal sinus beat. Okay, so the first three beats show a peak systolic pressure gradient of 25. So is that correct? That's about right? Because left ventricular systolic pressure is about 150 and aortic pressure is about 125. So the first three beats show a gradient of 25. That's correct. On the first sinus beat, after the PVC, the peak systolic gradient increased to over 100. Is that true? So this one, the LV pressure is 210, 220, and the aortic systolic pressure here is 100. So the gradient is greater than 100. This is a 50 grid, so this is more than 100. So the first sinus beat after the PVC over 100. That's true. Actually, we're going to do power vote on this one. Why don't you go ahead and vote? You already know the first two is true, so let's go ahead and vote. D. All right, very good. Very good. So that's the correct answer is D. So the first sinus beat after PVC, the pulse pressure is decreased. So the first sinus beat, so this beat after the PVC, you can see the pulse pressure instead of 125 over 50, now it's about 100 over 50. So that's decreased. And the increase in pulse pressure after PVC, so that you know already that's wrong. That's a decrease, not increase. This is the first, after the PVC, there's a reduction in stroke volume. What happened is this patient has what we call hypertrophic cardiomyopathy. So after the PVC, the first sinus beat, there's more vigorous contraction of the heart, so there's more obstruction in left ventricular outflow tract. So there's more gradient across that. So you can see the gradient across that is increased, and the stroke volume is reduced because there's more obstruction. So the pulse pressure is reduced after the PVC, and that's called Brocken-Brown wall sign. But this should be decreased, not increased pulse pressure. Okay, let's go through that. Okay, yep. I think we're done.
Okay. Questions? No questions.
Pick someone.
Okay, I think
we're
they're
ready for a
ready
break,
for a
yeah.
break. Dr. Wanpen, thank you.
Sure.
Oh, let's take maybe 5 minutes is enough? 10 minutes? Okay. 10-minute break.